Good evening and welcome. My name is Hannah Sahaunet, and I am a third-year medical student at St. George's University, and I will be tonight's moderator. Before we get started, I wanted to take a quick minute to invite you to officially join Doctors for America. Being a Doctors for America DFA member today means taking the important and simple step of selecting a membership level and paying your annual membership dues to support DFA's organizational sustainability. There are 6 different levels to choose from. A DFA team member will put the link to join in the chat. We will be live streaming to Facebook Live and making a recording. All materials will be available afterwards. A few quick ground rules for this educational session. There is no such thing as a stupid question. Number 2, speaking of questions, please remember to use the Q&A feature. We will address your questions during the second half of our session and also look out for comments in the chat. DFA staff will be sharing helpful links during the session. Now, on to today's speaker. We are thrilled to welcome Dr. Joe Adams. Dr. Adams is board certified in addiction medicine and internal medicine and serves as the medical director at Glenwood Life Counseling Center in Baltimore, Maryland. He is a member of the American Society of Addiction Medicine Public Policy Committee and is the chair of the Opioid Pain and Addiction Committee of MedChi, the Maryland State Medical Society. Thank you for coming today, Dr. Adams. And without further ado, I will pass it over for you.
Thank you, Hannah, and thank you. I want to thank Doctors for America for hosting this. Doctors for America is one of the few provider organizations that does not take pharmaceutical funding, so many other organizations would not feel comfortable hosting this type of talk, possibly. And I wanted to mention that in the past, when I had an internal medicine practice, I did prescribe long-term opioids for chronic pain in some patients. And I think in retrospect, I believe I may have harmed more people than I helped. And I was caught up in, the Purdue marketing situation that a lot of physicians did at that time. But now that I'm an addiction medicine physician, I kind of see this issue from a different perspective. I don't have any conflicts of interest to report. And this presentation will just refer to US data. And when I refer to chronic pain, that excludes cancer-related pain and end-of-life pain. And I'll use some abbreviations that are listed on your slide there. LTOT is long-term opioid therapy. MME, you can read the meanings of those. OUD, QOL for quality of life, and RCT. So our approaches to the opioid overdose epidemic are not working. That's pretty clear, I think. Things just keep getting worse. And the increase in opioid prescribing and the resulting epidemic of overdose primarily involves prescribing for chronic pain. And there is no substantial evidence that long-term opioids are effective for chronic pain. Nevertheless, the dominant continuing medical education on pain treatment through the FDA's REMS program is industry funded and promotes the message that long-term opioid therapy is often, quote, indicated for chronic pain. And I think that word indicated kind of implies that there is more certainty than really exists. It's really not clear, when people or if or when people should start a particular patient on long-term opioid therapy if they're opioid naive. These CME courses really emphasize whether and when to initiate opioids for chronic pain rather than how to treat chronic pain generally. And that's, kind of not surprising because that's the way the REMS program was set up for, a variety of medications and groups of medications. They really deal with one particular medicine or group. The great majority of overdose deaths occur in people with OUD. And how do people develop OUD? Most OUD occurs due to exposure to prescription opioids. And many Americans every year are developing OUD for the first time. It's an important factor in maintaining the opioid epidemic and the overdose epidemic. And that's probably, we have a prevention opportunity to do more in terms of opioid prescribing. That might help us to get on top of this issue. So to summarize the current evidence on opioid effectiveness, these are the findings of the government agency, these authoritative and very complete reviews and guidelines, and the Agency for Healthcare Research and Quality has summarized the data by saying opioids are associated with small improvements versus placebo, only versus placebo, in pain and function at short-term follow-up up to 6 months. And in 71 trials, randomized trials, the mean difference in pain intensity was less than 1 point on a 10-point scale. That's not clinically significant. Talk about that a little bit later. There's no difference when you compare long-term opioids for chronic pain versus non-opioid medicines. The benefits or the analgesic effects of long-term opioids for chronic pain tend to attenuate with time. The CDC said that there is insufficient evidence to determine long-term benefits of opioid therapy for chronic pain. The Veterans Administration guidelines in 2017 said that there's a mounting body of research detailing the lack of benefit and severe harms of long-term opioid therapy. Nevertheless, some people appear to do well on long-term opioid therapy and appear to have improvements in pain and quality of life based on long-term observational studies. And this is a review of 25 observational studies that some of the REMS courses refer to. They found that there was at about 6 months a significant, statistically significant, and also with a large, what is considered to be a large effect size of opioids to reduce pain without any clear change in quality of life or functional status. So these are observational studies. There are some limits to this kind of study. There's no control group, no placebo, no comparator. So we don't know completely exactly why people are doing the way they are. There may be other factors that are just not measured, but we do have a large number of randomized controlled trials, which is a better level of evidence to consider as well. This is the largest and most recent review of randomized controlled trials in opioids for chronic non-cancer pain from 2018, and they reviewed 80 randomized controlled trials compared to placebo, and opioids did reduce pain very slightly. These studies went up to 6 months. At least they just looked at studies that went at least a minimum of 4 weeks. About half of them lasted less than 3 months, and about half of them lasted 3 to 6 months. And again, just like the AHRQ results, the difference between placebo and opioids in these trials was very small, definitely less than 1 on a 10-point scale. And the authors note that a minimum of change of 1 point on a 10-point scale has been described as a clinically meaningful threshold for pain, citing this one article. And there have been other articles that have suggested that 2 points is appropriate for as a minimum meaningful change effect size for pain studies. So 1 to 2, but regardless, these studies on average didn't reach that threshold, but in some of the individual studies and probably some of the individual subjects probably did. This is the data from that study, and the black line would be no difference between opioids and placebo. The green line would be a whole 1 point of benefit on a 10-point scale, and the red dotted line is the mean of all of these studies. As I said, it was 0.68 reduction in pain. And you can see the studies on the bottom are the shorter duration studies, up to 3 months, and on the top are 3 to 6 months. And it does appear, and it really is, the data really does show that with time, whatever benefits exist, as small as they are, tend to be attenuated with time. Opioids in acute pain are highly effective, as we all know. They should not be withheld in appropriate circumstances. They have been shown to be no more effective than nonsteroidals in many circumstances in which they're commonly used. And short-term use is sometimes associated with an increased risk of long-term use over months or years. in a certain percentage of patients. So for most acute pain, it's recommended that opioids be limited to a 3 to 7 day supply. The only randomized controlled trial of opioids for what they described as slowly recovering low back pain was just published last month, or actually 2 months ago. They looked at 300 patients or so, and they just looked at less than 12 weeks duration of nonspecific low back pain and or neck pain, and found there was no benefit from opioids versus placebo. In fact, the opioid group was borderline statistically significant worse in terms of their pain. And the author's interpretation was opioids should not be recommended for acute nonspecific low back pain or neck pain. There's only been one long-term randomized trial for opioids for chronic pain lasting 12 months from 2018. And there were 240 patients, no difference in function, but the opioid group did slightly worse than the, I'm sorry, these are compared not against placebo, but this is compared against non-steroidal medications or other non-opioid medications. So the opioid group did slightly worse. It was statistically significant, but slight, and had more frequent side effects. So, I mean, this study really kind of is consistent with the other randomized trials that we've seen. Last year, the Veterans Administration Clinical Practice Guidelines on Opioids in the Management of Chronic Pain actually came out and said that their recommendation number one was, we recommend against initiation of long-term opioids for chronic pain, period. The strength of recommendation was strong. So the field may be changing especially with this report coming out. The REMS courses stands for Risk Evaluation and Mitigation Strategy, is an FDA program used for a variety of high-risk drugs. And the opioid REMS is based on a blueprint developed by the FDA with input from stakeholders, and notably significant input from opioid manufacturers, in a process that took several years of negotiation, it's been called. And during that time, the blueprint has changed. The blueprint is somewhat general. It's a little bit vague. It doesn't really say exactly what should go into the program, the educational programs. Manufacturers pay for the program, and they hire and select CME providers who develop the courses. So that's how the manufacturers apparently exert their influence. The CME providers are the medical communication companies that work and are paid for and selected by the manufacturers. They write all the content, and it is consistent with this general blueprint, but they write it up the way they see fit, and they're incentivized to write it in a way that the manufacturers would approve of. So they would be invited back and keep that business. This is a series of courses called the Scope of Pain. This one is offered by Boston University. They used to be called Safe and Competent Opioid Prescribing Education. They're part of the REMS program. Now they changed the title to Safer. It did sound better, but they use the word safe a lot in the content. And the purpose, they say, is to help you safely and effectively manage patients with acute or chronic pain with opioids. So, that's what these courses are largely about: how to, whether to, or when to, or how to initiate opioids, for acute and also definitely for chronic pain. And they tell you when opioid analgesics are indicated for chronic pain. And that word indicated, I mean, that does suggest more certainty or consensus than really exists. We don't really know when they're indicated. This is not a medical practice standard, except, outside of this course. Now, it is important to know about managing people on opioids for chronic pain, because there's about 8 million Americans on opioids for chronic pain now, and some of them, their doctors are retiring, and somebody needs to take over their care. And it is a problem that, not enough physicians feel comfortable or feel like they have the knowledge on managing these patients. So there is some useful information in that regard. But problem is that they do focus a lot on whether, when, and how to initiate long-term opioids in opioid naive patients, which is probably not a good thing, at least, to emphasize. This is the slide on efficacy for chronic pain. In the middle slide, they talk about that 12-month randomized trial. They don't mention the result on pain. They don't mention that in the slide. They just talk about the function. There's no improvement in function. And in the right panel, this is pretty much the way the course summarizes the evidence for opioids on chronic pain. This panel, which quoted the study on Noble, which I had showed before, that was a review of observational studies, and they said that 44, and the narrator states that about 44% of people had at least 50% pain relief, period. And that's, basically that's the message. It appears that opioids are effective for chronic pain. They don't mention that, they don't mention the randomized controlled trials. This is, they just mention these observational trials, and they don't mention the conclusions of the small effect size, or the conclusions of these organizations that I mentioned, the CDC, the VA, and the AHRQ. So it's misleading, I believe. And then, the title of the slide also suggests efficacy for chronic pain. When are opioids indicated? If pain is severe, has a significant impact on function and quality of life, pain type is potentially opioid responsive, inadequate benefit from non-opioid modalities. That probably describes most people with chronic pain. And if these were really the indications, then there'd be a whole lot more people on opioids. And that these are not the indications for initiating opioids for chronic pain, contrary to what that slide is presenting. This is not from the course, but this is the change over time in the volume of prescribed opioids in the United States from before the opioid epidemic in 1992 to about the current time in 2020. The volume in terms of morphine milligram equivalents is going down, but at this point, it's about double at 110 billion MMEs what it was in the beginning. It started out at 38 billion. So that's important piece of information to be aware of. But the way that they presented it in many of these courses, all the courses that I've reviewed, was they just report the data on numbers of prescriptions, and whether it's total or per capita numbers of prescriptions, it's true that the numbers of prescriptions have gone down to the level where we started before the opioid epidemic. So anybody who might have been concerned about overprescribing would be very reassured when they see that it appears that prescribing has gone down to what it was before the epidemic, but that's not the whole story. It's somewhat misleading. Here's a sample question real quickly. This is just a patient from one of the courses with who has worsening pain and function due to chronic arthritis. What should be the next step? Acetaminophen, duloxetine, ibuprofen, but the correct answer is oxycodone. Not really clear, if that really is the correct answer. There's some clinical features of the opioid epidemic that are not covered in the opioid REMS programs. As I mentioned, the great majority of fatal opioid overdoses occur in people with opioid use disorder, and people develop opioid use disorder, the great majority of them, as a result of prescription opioids. Per capita opioid consumption is greater than any other country in the world, and it's estimated that just in terms of initiating opioids after surgery, there are several millions of Americans that develop for the first time new onset long-term opioid dependence every year. So this is a slide, a form of this slide I've seen in all of the REMS courses that I reviewed. On the bottom here shows the decline in the number of prescriptions that I mentioned, juxtaposed with the increase in overdose deaths. And all of these slides sort of make a point of the fact that while prescriptions are going down, overdose deaths are going up. And here's what the narrator said to accompany this slide. And I've emphasized certain words here. Historical overprescribing and a massive and sustained exposure to opioids has fueled the opioid overdose epidemic in the US. But as of 2020, there are still pockets of the US where prescribed opioids are influencing the number of deaths. While the prescribing level has gone down, the number of opioid deaths has continued to rise at an alarming rate. So they're kind of, they're leaving the interpretation to the people taking the course, but they're sort of suggesting that there's no longer any relationship between opioid prescribing and opioid deaths. Of course, fentanyl now is overwhelmingly the proximate cause of opioid deaths, but that really occurs in people who have opioid use disorder, which they got in most of the cases from prescription opioids. And this data is presented here. This is a graph from the CDC data from last month in the Washington Post. They just had a very good graph on this. They looked at every county in the United States in terms of the number of opioid pills prescribed per person. And they ranked them by percentile on the left. And the highest percentile correlated 6 years later with the highest mortality rates in that county from heroin and fentanyl. And of course, we can see that prescription opioids eventually, often lead to people taking fentanyl or heroin or fentanyl and sometimes dying from it. So I think that's quite clear from the data. Also, throughout the entire epidemic, there have been parallel increase in opioid prescribing, opioid deaths, and opioid use disorder rates. So that's really helps to confirm that information. All of these courses are accredited by the Accreditation Council for Continuing Medical Education, the ACCME, as being free of commercial bias. But they do clearly have promotional messages coinciding with the opioid manufacturer's interest. There have been a few articles that explain why that might be. Most people don't really see the bias, because, it looks like an educational program. You sort of have to know the actual facts to really recognize the bias. Here's a article that came out of a group from Georgetown University, Increase Your Confidence in Opioid Prescribing, Marketing Messages in CME Activities on Opioids. They systematically analyzed all online opioid REMS activities in 2018 using a thematic analysis and found that there were 10 major themes and repeated statements, including opioids are an appropriate treatment for chronic pain. There is no population for whom opioids are absolutely contraindicated or inappropriate. And I've seen a number of these courses saying, well, if there's a history of substance use disorder, you can still prescribe, initiate opioids for the first time for chronic pain, but you would just monitor them more closely. Screening and monitoring tools are effective for preventing opioid use related problems. They do help, but they're not a surefire. Addiction and overdose are due to street drugs, not prescription opioids. And one quote was, you can never go wrong with opioids if you start low and go slow. REMS education has not been shown to reduce opioid prescribing or opioid harms. And in 2020, the HHS Office of Inspector General reported that the FDA was unable to really evaluate the REMS program in opioids because the data that the manufacturers were supposed to provide to the FDA were they both didn't really provide it completely, and it was unreliable, scientifically uninterpretable. So we just don't, there's no evidence that they help. There's a couple of critical decision points in opioid prescribing that are not covered in these REMS courses. There's a tremendous difference in the threshold of whether you're going to prescribe for acute pain or chronic pain, which is not discussed. And for chronic pain, there's a tremendous difference in the threshold whether you're going to initiate opioids in people who are opioid naive versus continuing opioids if they're already dependent. Of course, those are like night and day situations. And in chronic pain, the limitations of therapeutic trials of starting an opioid, the limitations are downplayed somewhat. So, when you start in these courses will often, this is not actually a bad thing to do. They say when you're initiating opioids for long-term chronic pain, you should consider it to be a therapeutic trial. And if it doesn't work out, when you see the patient next month or so, you can taper it off. It's not that clear and it's not that easy. And I think they downplay some of the complexities of tapering. And also the fact that initially, people are going to feel much, much better in the short run from their pain, maybe from the psychic pain or also from the analgesia, which is more effective early on. And side effects, physical dependence develops early, making it difficult to taper later. So, and here's some information about tapering. Basically, tapering, I'm going to skip over some of these slides for the interest of time, but tapering has been associated with improvements in pain and function and quality of life. Most patients did not result in complete discontinuation, but tapers are risky, possibly, especially in people with aberrant behaviors, possibly even in stable patients. So it should be done with a lot of respect. There are some patients on long-term opioid therapy that are not able to come off of opioids. This term complex persistent opioid dependence has been used. It's not really well defined, but it kind of describes a group of people who have, may have aberrant behavior. There's some features of opioid use disorder. They're very intolerant to tapering. And so it may be that, some people develop this type of physical dependence that is not easily reversible. And it is a, quote, a serious consequence of long-term pain treatment. So it resembles in some ways opioid use disorder. For many patients treated with opioid use disorder cannot and probably should not be tapered necessarily. 1 out of 10 patients on long-term opioid therapy has opioid use disorder, 1 out of 10. And 1 out of 5 approximately has opioid misuse or aberrant behaviors. So it's a high rate. And likely these things were really caused by their opioids. Often these conditions are not recognized. So what to do about aberrant behaviors in long-term opioid therapies? There was I saw quite a number of trials, but only one that actually had some positive benefit in reducing the risk of misuse by this index, where they had a monthly intervention for 6 months in a randomized group that was randomized to that treatment, had a significant effect in their risk. But I'll give you a clinical pearl, and that is with aberrant behaviors, running out of prescriptions early and that sort of thing. Careful, repeated screening for opioid use disorder while normalizing craving and loss of control so that you can get accurate information from the patient. So you might say to the patient something like, it's not uncommon for people to find that they sometimes use medicine for stress, thinking about their next dose often. Maybe they like the medicine too much, or maybe they sometimes have trouble controlling the number of pills that they take. If you've experienced anything like this, don't worry, I believe I can help. So how do you help? Well, if they have opioid use disorder, treat or refer for opioid use disorder. And if they don't meet the criteria for RUD, if they fall into this category of complex persistent opioid dependence or just aberrancy, then you may treat them as if they had opioid use disorder, but you would not be formally treating them for opioid use disorder because you're not allowed to with some of these medications. You would be treating them for pain. You could treat them with methadone or buprenorphine. Well, you can't treat opioid use disorder with methadone outside of an opioid treatment program, but you can use it for pain. However, methadone is dangerous, and initiating methadone is very tricky. And there have been a lot of overdose deaths in pain clinics related to methadone because of its unpredictable and very prolonged half-life. But you could also use buprenorphine, although you'd have to transition somebody to buprenorphine, and that you may use one of the new techniques to do that, where you would overlap and microdose so they don't have to taper off of their full opioids first necessarily. So it is illegal to prescribe medications for opioid use disorder with any medication that's not FDA approved for opioid use disorder. But of course, you would be treating for pain in those scenarios. So I was surprised when I learned that the new onset among people who are opioid naive, the new development of persistent opioid use is a common surgical complication, one of the most common, from 5 to 10%. And with the second study listed there, they looked at both minor and major surgical procedures, and they had the same rate of new onset of persistent long-term opioid use. There have been successful reductions of opioid prescriptions in hospital. And the top study there, they were able to reduce the morphine milligram equivalents after laparoscopic cholecystectomy from 250 down to 75 milligrams after a educational intervention without any change in pain or refill requests. It was somewhat of a intensive educational program, and they did track hospital physicians' use of opioids, but it was very effective. And the group at this organization called OPEN from Michigan, Opioid Prescribing Engagement Network, used evidence to develop a list of numbers of oxycodone tablets that are often used or frequent, for most people, are adequate for different surgical procedures. So that was very helpful for anybody. There's another surgical collaborative in Wisconsin of this type. I don't think there's too many of them, and still in the rest of the country, I think we're still overprescribing opioids post-operatively. Overprescribing opioids causes harms, and Dr. Nora Volkow, along with her co-author here, she's the director of NIDA, National Institutes of Drug Abuse. She makes it very clear that overprescribing has been a driver of opioid use disorder, and notes that OUD is an important risk factor for overdose deaths related to the availability and the amount of prescriptions for opioid pain medicine. And if you look at any of the government health websites, NIH, HHS, CMS, CDC, right now they all have something on their website that addresses the problem of overprescribing. So they think it's still a problem, and it still is. However, reducing overprescribing can also cause harms. It's tricky, it's nuanced, and it's risky. And there have been plenty of patients that have gotten into trouble because of physicians and providers being reluctant to continue their opioid pain medicine. So in the years that followed the 2016 CDC guidelines for chronic pain, that is the original guidelines, which were probably overinterpreted, people who were tapering off of opioids were 3 times more likely to die of an overdose. These legacy patients on chronic opioids for pain sometimes are not able to find a physician to continue their medication. We want to reduce irresponsible prescribing, not irresponsibly reduce prescribing. And we also do want to reduce initiating long-term opioids in opioid-naive patients for chronic pain, although some people may still be initiated on that. The field is changing. This is the best course for physicians that I've seen. It's online at the ASAM website, American Society of Addiction Medicine. This tells you how you can find it, presented by Dr. Donald Teeter. And toward the bottom of the slide, I'll just mention something that he said there. First, I should say that in every other course that I've seen, including the course from the CDC, the courses on the other websites, the providers, clinical support system website on opioids for chronic pain for providers, they always pretty much say that you should only initiate opioids for chronic pain if the benefits are expected to outweigh the risks. The problem with that is that it's not very clear guidance. It's not always clear what that means. And so Dr. Teeter said, it should be a rare patient where we initiate opioids for chronic pain. I think that's probably true, or at least I agree with that statement. And it's more specific. It's a kind of a more clear guide. And Dr. Teeter also suggests that if physicians are considering starting a long-term opioid for chronic pain, buprenorphine would be preferred due to safety. It's a partial opioid. And that's the same conclusion that the Veterans Administration 2022 guidelines came to as well. They said, they recommend not to initiate opioids for chronic pain, but if you do, buprenorphine would be preferred because it's safer. Buprenorphine has also not been shown to be effective for chronic pain, but at least it's a lot safer than full opioids. And also we know it is effective for shorter term pain. So from this course by Dr. Teeter, he points out that for chronic pain, behavioral approaches become more important than medication approaches. Using CBT and similar approaches, thoughts and emotions become the major driver of chronic pain. In chronic low back pain and other conditions, long-term outcomes are often worsened by the use of long-term opioids. And there are similarities between chronic pain and opioid use disorder, including the fact that for either condition, once you've been on opioids for a while, it may be unwise or difficult or possibly impossible to taper off. So people, I know certainly people with opioid use disorder very often are just do better when their medicine is continued for as long as it's needed, possibly long term. The same may be true for some people on opioids for chronic pain. This is kind of a new approach, it's kind of a psychological approach called pain reprocessing therapy. And the author of this randomized controlled trial pointed out that chronic back pain, 85% of it, for 85% of it, a peripheral etiology cannot be identified. And maintenance factors include fear, avoidance, and beliefs that pain indicates injury. So this therapy helps patients reconceptualize their pain as due to non-dangerous brain activity rather than peripheral tissue injury, and they use motivational interviewing to encourage activity, physical activity. And they gave this intervention for 4 weeks to this with 2 randomized control groups. And you can see in the image, after the 4-week treatment, there was quite a large difference in achieving a pain-free or nearly pain-free state. But they also, most of the benefits were maintained after a year after this 4-week treatment. And this sort of goes by another name as well, pain neuroscience education. There have been a number of studies on that as well. The traditional psychological interventions have shown small to moderate reductions in pain intensity, such as CBT, acceptance and commitment therapy, behavioral therapy, social support, and modest improvements in catastrophizing, beliefs, physical functioning, and some improvement in improving mental health. This is a great 2-page handout for patients. This is one of the pages. And what should I know about opioids and living with chronic pain? So I like this better than the handout that's available on the CDC website. They talk about they talk more about the possibility of tapering, and they point out that studies show that if opioids are decreased slowly, pain and function can actually improve. Now, as I mentioned before, and I provided a reference that that's not clear cut. Any kind of tapering can be risky, more so in people with aberrant behaviors, but possibly in anybody. So, but I think that this is a great resource. And this is a really excellent 5-minute video for patients. It's a narrated, animated video, and it's really about the role of modifiable nervous system sensitivity in chronic pain, and that's really, needs to be addressed in treating chronic pain. So I really recommend that. Healthy brain habits. healthy nervous system and immune system habits, bad habits for brains. Here's some more slides. Fear is a big factor, anxiety, fear of making the problem worse. And here's a couple of provider resources. I mentioned pain reprocessing therapy. Well, Dr. Schubiner, who has been interviewed in a podcast episode that I thought was good, and he kind of explains that approach. Lucid Lane is an organization that provides virtual opioid tapering services or behavioral health services in general, really virtually, and billing most commercial insurance carriers. So that could be helpful. Farmed Out at Georgetown has authored some of the articles that I presented, and they also, of course, don't accept pharmaceutical financial support, and Physicians for Responsible Opioid Prescribing. These two organizations really are on the forefront of this issue that I've been describing, and I support them, and I think they deserve our support, along with Doctors for America. Here was an article in Mother Jones, which was great. It was called "Doctors Receive Opioid Training, Big Pharma Funds It, What Could Go Wrong?" It doesn't look like promotion, it looks like education. Here's a couple of other articles in the literature. This may sting a bit, cutting CME's ties to pharma. This was a very influential report, recommendations on the opioid prescriber crisis, published last year by a very prestigious group of authors. These are people that are leaders in the field of addiction and pain. And their first key message in the report was, profit motives will continue to generate harmful overprovision of addictive pharmaceuticals unless regulatory systems are fundamentally reformed. Now, of course, be nice if we had some really great training courses for prescribers on this issue. And we do have at least one. This is a course that I mentioned earlier by Dr. Teeter. This is the best one that I've seen. I'm still looking for them. My comments on these various courses are indicated in this red and yellow type. So I reviewed the CDC's course on this topic, and I did have some criticisms, but most of it was excellent. Of course, like all the courses, the bottom line is consider initiating opioid therapy if benefits are expected to exceed the risks. Not very clear, not very helpful, but also they had a case which I thought wasn't ideal, where they just ended up prescribing opioids for chronic pain abruptly without really involving the patient in the discussion about it. But overall, that was good. There's a number of training activities on the website PCSS, and most of these courses, in my personal opinion, had some very good points and some points that I disagreed with. So there are several of these as we go down that you can read. These slides are available. They're online right now, as I understand, so you can use them as a reference if you'd like. I'm not going to go over buprenorphine for chronic pain, but that is a a good option, and I hope that becomes more prevalent. Like I said, I mean, you start somebody on buprenorphine, they would develop opioid dependence, and it hasn't been proven to be effective for chronic pain, but it has some significant advantages, and it is possible to transition people from full opioids to buprenorphine, and there's some new methods for doing that. So I'm going to skip these last two slides, and if to allow time for discussion, but this is my email address. Please contact me for questions, comments, or just to let me know that you're interested. I'd love to know that, because we'll be continuing to work on this. Doctors for America has a subcommittee on substance use disorder that I participate in. They also have a committee on the FDA. And, we are, working on, in general, issues of this type. So I hope you join us in that. And thank you very much.
Sorry. Thank you, Dr. Adams, for that insightful presentation. There have been a couple questions shared. Again, guys, I encourage you all to use the Q&A feature to enter a question. So I guess to start with the first question, you have discussed how overprescribing and underprescribing can cause patient harm. What do you, as a provider, think would be the best recommendation as a new doctor to prevent overprescribing opioids?
Learn how, the many ways of addressing chronic pain. And it's not necessarily an easy thing to do, because really, if you're faced with a patient with chronic pain, it's believed that multimodal therapy is probably the best. So psychological therapy, physical therapy, and medications, maybe non-opioid medications. You need to really take the patient seriously, develop a rapport. Nowadays, there's an expectation that they're going to get opioids for their pain. So that may complicate things. And that might be a scenario where you might feel compelled to start buprenorphine, but I wouldn't do that if, you don't think it's indicated or if it's not necessary. Learn, look at Dr. Teeter's course, look at some of the other courses. They have a lot of information on various medications and various psychological treatments that you can use. You can also refer to pain medicine as well.
Thank you. We have another. What can we do at our own institutions to encourage non-pharm opioid prescribing education?
I would like to join you in that effort. So send me an email if you're interested in doing that. There's a lot of aspects of medical education that are really under taught or don't have enough time in the schedule. And definitely treating chronic pain is definitely one of them. There's very, very little training for chronic pain. And as a result, most physicians get their information from these REMS courses, which are industry influenced. I think if medical schools would provide training, that would not be influenced by the industry. That would be the industry can't really get into the medical schools and determine any aspect of the content of a medical school course. So that sounds like a very good approach to addressing this problem, and I would be happy to join you in some of those efforts. So please send me an email.
Thank you. We have another. Post-operatively, when managing a patient's pain, what would you recommend be the course of action?
Now, I think many patients really do kind of inadvertently develop long-term opioid dependence, as I mentioned, after surgery. And I think it only takes a couple of refills before it becomes hard to taper off. So that time after surgery is really critical. When a patient, I think most people are going to be discharged on an opioid prescription, hopefully not a 60-day prescription or a 30-day prescription, but and whoever's responsible for monitoring the patient post-operatively, usually it's the surgeon, has the challenging job of tapering the medicine off before the patient really gets physically dependent and has a difficult time. And many people just end up on long-term opioids if that's not done. Of course, you can always avail yourself of that resource that I mentioned, Lucid Lane, that provides de-prescribing services virtually and billing the patient's insurance. I mean, our medical system is not necessarily set up for treating people with pain in the best way, because multimodal therapy is not reimbursed as well as it should be. Even just caring for pain, which can be more time consuming and complex, is not really reimbursed appropriately either. I think there may be some people who need pain for a longer period of time. And if they do, that's your judgment. I mean, that if somebody has a very, very painful condition, nobody is to say that you have to taper it off, within a certain time period. But it is easy just to kind of if you're not really very careful and intentional about it, it's easy to sort of unintentionally convert somebody from short-term pain to long-term pain. So and of course you can involve your colleagues. If as a surgeon, maybe you don't have time to deal with this issue, but I think that should be part of a surgeon's role as well.
Thank you. So that was the last question within the Q&A. If anyone else wants to ask a question, now is the time. I'll give it another minute.
I've been kind of thinking about ways that we can address this problem, and I was thinking that possibly we could try to reproduce some of the success that this surgical collaborative in Michigan has had, where hospitals, I believe, do have information on the hospital-based physicians' opioid prescribing, and if that were made public, or if we were able to see how they're doing, I think that would help a lot. So I'm probably going to try to look into that in Maryland and see if we can, because this has been done very effectively in at least one or two other states.
Great. Just going over that, or off that rather. We do have another question here. 1 second. Do you think it would be possible to revamp medical school education to include more pain management? So for instance, discussing opioid use disorder. And is there a way to target medical school accreditation process?
I have not really gotten involved in that, but I would like to. I mean, that's a great way to address this problem, to give people education or alternatives to these REMS courses. I know that there is also a effort to increase the medical school education on treating opioid use disorder as well. So, I mean, given the size of this epidemic that we have, that are really closely related to one another, both of these conditions, opioid use disorder and pain, really do need to be taught in a sensible way in medical school. So any effort to do that, I think, is really worthwhile. I don't know exactly how to do that. I'm sure it's not easy. I'm sure there's a lot of communication and advocacy that has to go on by a group of people and a group of organizations. So I hope we move in that direction.
Great. Sounds like a good area to explore. We do have another question. What treatment recommendations would you have for someone with OUD, say an OTP, and chronic pain? And what do you do in your own practice?
Well, there are a lot of people I work in an OTP, and of course, there's a lot of patients with pain. I mean, there's such an overlap between pain and addiction, especially OUD. So there are people who feel that they need to be on opioid for their pain in our population. And if somebody is in, quite a few people have sought out pain medicine doctors or primary care doctors who are treating their pain with opioids, and they don't always know that the patient's on methadone, if it's methadone or whatever the medicine they're on from an OTP, because that is not available through the PDMP. So I feel that we should discuss things with the doctor. I like to determine whether somebody meets the criteria for what I used to think were the criteria for being treated with pain for opioids for pain would be, severe impairment in function, which is significant impairment in function, which is significantly improved by the medications. So if they have that, we would try to split the methadone dose, and sometimes that works very well, or split the buprenorphine dose. So that would be the first thing to try. But if we don't require that they come off of their opioids necessarily. I don't think they're necessarily hurting anything if they're already on methadone. But we discourage them from being on opioids in most cases for pain. But at the same time, we want to acknowledge their pain and try to help them with it.
Great. Thank you guys for all those questions. So I would like to close today's event by thanking Dr. Adams for his thought-provoking discussion. Watch for opportunities to join related presentations. We're so grateful you were able to join us. Before you leave, here are a couple quick reminders. If you registered to attend, you will receive a copy of the presentation and slides as follow-up. Thank you for being here and for all you do on behalf of patients. We hope you will become an official DFA member today and take a look at the benefits of membership on DFA's website. The number one reason doctors, medical students, and health advocates join DFA is to be with like-minded people that share the same values and priorities. Please remember to follow us on Twitter, LinkedIn, and Facebook to stay up to date with all the DFA programs, events, and ways to get engaged. Thank you.